Welcome to The Deep Dive, the show where we take a whole heap of sources, articles, research, you name it, and really boil them down to the key insights, giving you that shortcut to being genuinely well-informed.
Yeah, cutting through the noise.
Exactly. So, when you think about healthcare, what usually comes to mind? Maybe, that amazing surgeon or really compassionate nurse, or even some breakthrough medical tech.
Sure, the high-profile stuff.
Right. But behind all that, there's this constant, almost invisible effort going on to make healthcare better, safer, more efficient for absolutely everyone.
It's not just about fixing you when you're sick, it's about the system working as well as it possibly can.
Precisely. It's about ensuring the care you get isn't just, okay, but that it's relentlessly pushing for excellence.
Always improving.
Okay, let's unpack this.
Huh.
Today we're diving deep into something that, might sound a bit technical at first, but honestly, it's utterly foundational to good healthcare. Continuous quality improvement, or CQI. Think of it as the quiet engine humming away behind the scenes, always pushing for a smoother ride, a more effective treatment, a more patient-centered experience for you every single day.
That's a great way to put it. And for this deep dive, our main guide is this really comprehensive scoping review by Endalamaw and colleagues, just out this year, 2024.
Fresh off the press.
Pretty much. And they've synthesized a huge amount of research on CQI in healthcare. They define it as a systematic, ongoing effort to fundamentally improve healthcare processes and, crucially, patient outcomes.
So systematic and ongoing. Keywords.
Absolutely. So our mission today is to pull out the most critical, maybe even some surprising insights from all that work. We're basically giving you the highlights, a shortcut to understanding how healthcare is constantly trying to get better, safer, more reliable.
Gotcha.
So whether you're, a patient navigating the system, or maybe you work in healthcare, or perhaps you're just curious about how these big, complex systems actually evolve.
Which healthcare definitely is.
Oh, absolutely. This deep dive will hopefully reveal the nuts and bolts of how quality gets built, how it's sustained, and how it's improved in health systems all over the world. It's really about understanding that relentless pursuit of making things just a little bit better day after day, turning challenges into chances to grow.
All right, so let's start right at the core. Continuous quality improvement, CQI. What does it actually mean in a healthcare setting?
Well, the review really stresses that it's way more than just a buzzword. It's framed as this crucial, proactive initiative, transformative even.
Proactive, okay, not just reactive.
Exactly. Specifically aimed at enhancing quality across the entire health system. It's like the system commits to never just standing still, always looking for ways to raise the bar, ensuring you get the best possible care.
And why is this so critical in healthcare? I mean, anyone who's interacted with the system knows it's incredibly complex, isn't it?
It's a beast, yeah. You've got so many moving parts: access to care, patient safety, which is huge, keeping up with medical advances, coordinating care between different doctors, different clinics.
Making sure it's actually centered around the patient's needs, not just the system's convenience.
Precisely. And monitoring the quality of all that. CQI is essentially designed as this dynamic, evolving strategy to tackle all those multifaceted issues head on.
Which is why you said it's not a one-off fix.
Yeah.
It's not a project you just complete and tick off.
Definitely not. That's the continuous part. It's an ongoing process. Building a system that learns, that adapts, ensuring that today's best practice, tomorrow we can probably make it even better.
It's the mechanism for self-correction, basically.
Exactly. Constant growth and self-correction.
And that continuous idea, that drive to adapt. Where did it come from? Does it have roots outside of healthcare?
Oh, absolutely. It's got quite a fascinating history, actually, that predates its widespread use in healthcare. It really started to formalize back up in the early 20th century with a guy named Walter Shahart.
Sure.
Yeah, he was working in manufacturing, believe it or not. But his insight was realizing that quality wasn't just about checking the final product and throwing out the bad ones.
Right, not just inspection at the end.
No. He argued you have to build quality into the process itself right from the start. He laid out 3 basic steps. First, you specify exactly what quality means for what you're making. Then, you produce it carefully to meet that specification. And finally, you inspect to make sure it measures up.
Seems logical now, but I guess it was groundbreaking then.
It really was. It shifted the whole focus from finding errors after they happen to preventing them by improving the process.
Okay, so that's Shahart. Then what?
Then, fast forward to the 1950s, and you have W. Edwards Deming, another giant in the field.
Deming, I've heard that name. PDSA cycle.
That's the one. He took Shehart's ideas and really expanded on them, developing what became known as the Plan Dose Study Act cycle, or PDSA. Sometimes people say PDCA, Plendo Check Act. Same idea.
And he applied this. Where?
Initially, in management, particularly in post-war Japan, it pretty much revolutionized their industrial production.
How does PDSA actually work, in simple terms?
Think of it like the scientific method, but for improvement. You plan a change you want to make. You do it usually on a small scale first, like an experiment. You study the results, what happened, did it work, and then you act based on what you learned.
So you either standardize the change if it was good, or you tweak it and try again.
Exactly. It's a cycle, it's iterative, you keep looping through it, learning and refining. And eventually this powerful idea made its way into all sorts of fields, including healthcare.
That makes so much sense, seeing that lineage from manufacturing.
Yeah.
The healthcare. It's different, right? People aren't widgets. When did healthcare really start embracing these ideas? Who were the pioneers there?
Yeah, it's definitely a different context. The review suggests the sort of earliest seeds of quality improvement in healthcare might go back even further, all the way back to Florence Nightingale in 1854.
Nightingale. Really? Wow.
Yeah. Long before any formal CQI models, she was essentially doing quality improvement documentation. During the Crimean War, she wasn't just caring for soldiers, she was meticulously recording data on patient outcomes, mortality rates, the conditions in the hospitals. She realized that systematic observation, collecting data, was crucial to understanding and improving outcomes. She used data to push for better sanitation, better care practices. She was measuring to improve. That's the heart of CQI right there.
That's incredible. So she was data-driven back then.
Absolutely. Then, jumping forward, the theoretical side got more formalized. In 1966, Avedis Donabedian developed this really influential framework for thinking about quality of care. It's still widely used.
Donabedian, what was his framework?
He broke quality down into 3 interconnected bits: structure, process, and outcomes.
Okay, structure, process, outcome. What do those mean?
So structure is about the setting and the resources, the hospital building itself, the equipment, staff training, that kind of thing.
Foundations.
Right. Process is about the actual actions taken in delivering care, how a diagnosis is made, how medication is given, how you get patient education.
Just doing part.
Exactly. And outcomes are the results. Did your health improve? Is your pain less? Did the treatment work? This framework gave people a systematic way to actually evaluate quality, moving beyond just gut feelings.
That's super helpful. Structure, process, outcome.
Then, even later in 2001, the Institute of Medicine in the U.S. expanded on this. They identified 6 key components of quality care that are still really central today.
6 components. Okay, what are they?
They are effectiveness, so care based on scientific evidence; efficiency, avoiding waste; equity, care shouldn't vary just because of who you are; patient-centeredness, respecting your preferences and values;
Yeah.
safety, avoiding harm; and timeliness, reducing waits and delays.
Effectiveness, efficiency, equity, patient-centeredness, safety, timeliness.
Are-
Yeah, but these are all things CQI tries to improve.
Exactly. They're explicit targets for CQI efforts. And bringing it right back to CQI itself, in 1991, G. Cooperman specifically applied this continuous improvement thinking to healthcare. He outlined 5 key steps for actually doing it.
Cooperman, okay. What were his steps?
First, pick a specific process you want to improve, maybe patient check-in, or how test results are handled. Second, get an expert team together who really understand that process.
The people doing the work.
Right. Third, map out the key steps in the process and what good outcomes look like. Fourth, collect data, objectively measure those steps and outcomes. And fifth, crucially, feed that data back to the people doing the work.
So they can see what's happening.
Exactly. Empower them to see the impact and make adjustments. This really provided a practical pathway for hospitals and clinics to start using CQI principles, moving from abstract ideas to actual practice.
That history is really clear now. From Shehart and Deming in manufacturing, through Nightingale and Donabedian in healthcare, to Cooperman making it practical. So when we talk about CQI's core identity today, it sounds like it's more than just a method. What really sets it apart, I hear terms like QA, quality assurance, or TQM, total quality management. How is CQI different?
That's a really important distinction. CQI's core identity is about fostering a specific culture, a culture of continuous learning, innovation, problem solving. It's about engaging employees, empowering them, building trust and respect, all aimed at better care.
So it's a mindset shift.
It really is. Now compare that to, say, quality assurance, QA. QA is vital, but it mostly focuses on checking things after they happen, identifying errors or deviations from a set standard, making sure things meet minimum requirements are good enough.
Like quality control on an assembly line.
Kinda, yeah. It's more about auditing against a standard, a gatekeeper function, pass or fail.
Okay. And TQM, total quality management.
TQM is broader. It's a whole management philosophy aimed at improving all aspects of an organization continuously. It's like an overarching umbrella covering everything. CQI, as the review highlights, is more specific. It's the ongoing iterative process improvement engine within that bigger picture.
So TQM is the philosophy. CQI is a specific engine for improving processes.
That's a good way to think about it. CQI builds that cycle of improvement directly into how healthcare operates, constantly refining specific processes rather than just auditing them or managing the whole company strategy. It's proactive, preventative, always evolving.
Got it. Not just checking boxes, but really embedding that improvement philosophy. And operationally, the review says CQI is cyclic, ongoing. What does that actually look like in practice? Cyclic, reflexive, analytical, iterative sounds impressive, but how does it work day to day?
It works as a loop, a series of connected steps that keep repeating. You start by identifying gaps where things not working as well as they could.
Finding the problems.
Right. Then you generate data about those gaps, really understand the problem quantitatively. Next, you develop and implement action plans to address those gaps, often starting small, testing things out.
Like the do in PDSA.
Exactly. Then you evaluate the performance of those actions. Collect more data. Did the change make a difference? Critically, you provide feedback to everyone involved. Share the learning. And based on that feedback, you propose adjustments, refine the plan, and start the cycle over again.
So it literally never stops.
Ideally, no. It's a continuous feedback loop, always refining itself.
And for that loop to work, you need commitment, right? From the top down.
Absolutely crucial. The organization needs a deep commitment to this philosophy. They need a clear mission statement for quality. Everyone needs to understand what quality actually means in their specific context. Is it reducing infections, faster appointment times, better communication?
Defining what good looks like.
Precisely. And this involves setting up patient-oriented measures and performance indicators. The focus isn't just internal stuff. It's about satisfying both internal customers, the staff, the different departments and external customers, the patients and their families. You develop strong QA practices as a base and agree on common quality measures everyone uses.
Okay, one thing that really jumped out at me from the review, and it sounds, well, challenging, is how CQI handles success and failure. It talks about celebrating both, fostering an error-free attitude by seeing failures as system issues, not blaming individuals. That no-blaming culture sounds amazing, but how do organizations actually do that? Especially in healthcare where the stakes are so high.
You've hit on probably one of the most critical and, difficult parts of CQI culture. It explicitly demands an environment where people feel safe to talk about errors. The error-free attitude isn't about pretending mistakes don't happen. It's about reframing them.
How so?
Seeing failures as problems with the system or the process, not as someone's personal fault. The source is clear. Success and failure are linked to organizational processes, not individuals. This completely changes the dynamic. A gap or a failure isn't something to hide anymore.
It becomes data.
Exactly. It becomes a greater opportunity for learning, for building a data-driven learning organization.
But how do you get people, especially leaders, to actually behave that way?
Leaders have to model it. They need to openly discuss errors as learning points. Ask what went wrong with our process, not who messed up. Many places implement just culture principles.
Just culture.
Yeah, it means you differentiate between honest mistakes or system flaws, which are treated as learning opportunities without blame and reckless behavior, which does have consequences. This builds psychological safety. Staff feel secure enough to report errors, near misses, system problems, and that reporting is invaluable data for improvement.
Without that SACI, the data dries up.
Completely, and true continuous improvement just stops.
You mentioned teams earlier. The review says CQI cannot be implemented without a CQI team. It's not a solo job.
Definitely not. It's inherently collaborative.
Yeah.
A typical CQI team is multidisciplinary. You need different perspectives.
Like who?
You'll usually have a team leader guiding the process, a subject matter expert, maybe a doctor, nurse, therapist who deeply understands the clinical area you're trying to improve, a data analyst, someone who can crunch the numbers and show trends, a facilitator to keep meetings on track and help the team collaborate effectively. Crucially, frontline staff, the people actually doing the work day in, day out, their insights are priceless.
Makes sense. They know the reality.
Absolutely. And sometimes you might even bring in external stakeholders or partners for fresh perspectives. This mix ensures that any improvements are practical, well-rounded, and actually work because they consider all angles.
Okay, last thing on operations, the timeline. How long do these CQI cycles take?
There's no single answer, but the review highlights a strong consensus for keeping the cycles relatively short.
Why short?
It allows for continuous feedback and quicker adaptation. You're not waiting ages to see if a change actually worked. The review mentions examples ranging from just 2 months up to maybe a year and a half, but often with data reviews happening much more frequently, like bi-weekly or monthly.
So constant tinkering, constant learning.
Pretty much. The key isn't about finding one quick fix. It's about consistent, measured progress through these adaptable, fairly short cycles that allow for rapid learning and iteration.
Okay, so we've got the philosophy, the culture, the team-based iterative rhythm. But let's get practical. How do healthcare systems actually do CQI? What are the specific models and the tangible tools they use to make this continuous improvement happen on the ground? This is where the rubber meets the road, right?
Exactly. This is the how-to. And the Endalamaw review details a whole range of CQI models, each with its own steps and best applications. But there's one that really stands out as the dominant player.
Which one is that?
The Plan-Do Study Check Act, PDSA cycle. We touched on it earlier, but it's cited as the most commonly used model worldwide. Its strength really lies in its simplicity and how adaptable it is.
The scientific method for improvement.
That's it. Let's walk through the steps again, quickly, in this context. You start with project initiation to find the problem. Maybe reducing patient falls on a specific ward. Then, situation analysis, understand the current state. Get baseline data on fall rates.
How bad is it now?
Right? Then, root cause identification. Why are patients falling? Is it staffing? Medication side effects? Environment. You dig deep. Then solution generation and selection, brainstorm fixes, choose the most promising ones.
Okay.
Then implementation, try out the solution, maybe a new bedside assessment tool, often on a small scale first, like on that one ward. Result evaluation, collect new data. Did fall rates go down? Standardization, if it worked, make it the new standard procedure everywhere. And finally, future planning, what's next? What else can we improve? The cycle starts again.
Can you give a quick example?
Sure. Imagine a clinic wants to improve diabetes management. They plan to implement group education sessions. They do it with a small group of patients for a few months. They study the results, look at blood sugar control metrics, patient feedback. They act. Maybe they find it works well, so they expand the program. Or maybe they find patients prefer one-on-one, so they adjust their plan and try that. It's that constant loop.
That PDSA cycle seems like a really solid core engine. But you said there were other models mentioned. Do they build on PDSA, or are they totally different?
Many of them definitely build on or complement PDSA, maybe adding extra steps or emphasizing different aspects. For instance, there's OCS PDCA.
FOCSS, what does that add?
It basically adds a structured set of steps before you even start the PDCA cycle to make sure you're aimed correctly. FOCS stands for Find a Process to Improve, Organize a Team, Clarify the Current Process, Map it out, Understand the sources of variation or problems, and select the specific improvement to target.
So it's like a preparation phase for PDSA.
Exactly. A pre-flight checklist for your improvement project. Similarly, there's the FAD cycle. Focus, identify the problem, analyze, understand it with data, develop solutions, and execute, implement. Again, a structured, iterative approach.
Okay, so variations on the theme. Any radically different models?
While some have different structures, the logic framework approach is more analytical, almost top-down. You brainstorm issues, do a deep root cause analysis to create a problem tree, visually mapping causes and effects. Then you flip it to an objective tree, mapping solutions to those problems. Then you formulate the project and execute.
Sounds more complex. When would you use that?
Probably for really complicated multi-layered problems where you need to understand the whole causal chain before you jump in.
Makes sense. What else?
There's the breakthrough series approach. This one's interesting because it's highly collaborative. It involves CQI teams from different places, maybe multiple hospitals meeting regularly, like quarterly learning sessions.
So they learn from each other.
Precisely. They share experiences, successes, challenges, learn from each other's experiments. They have ongoing discussions between meetings, too. It's designed to accelerate improvement by spreading good ideas faster. Imagine a bunch of teams tackling the same problem, like reducing sepsis rates and constantly sharing what works.
That sounds powerful. Leveraging collective intelligence.
Definitely. Then you have the whole lean approach. This comes from manufacturing, Toyota, famously, but it's incredibly effective in healthcare.
Lean is about waste reduction, right?
Exactly. Identifying and eliminating anything that doesn't add value for the patient. Waiting time, unnecessary movement, duplicated tests, paperwork errors, all seen as waste. Lean is often combined with Kaizen principles.
Kaizen. continuous small improvements.
Yes. Kaizen emphasizes that everyone can contribute ideas, focusing on practical, low-cost improvements, using data, acknowledging problems without blame, reducing variability, and empowering frontline workers. It's a philosophy of constant incremental betterment.
And within Lean, there are other tools.
Yeah, like the 5S principles. These are for workplace organization. Seems simple, but think about a busy ER or operating room. 5S's. Sort, get rid of clutter, set in order, organize what's left, shine, keep it clean, standardize rules to maintain the first three, and sustain, make it a habit. It boosts efficiency and safety.
I can see how that would help. Less time searching, fewer mix-ups.
Exactly. And for more complex, data-heavy problems, there's Lean Six Sigma, often using the DMAIC methodology.
DMAIC. Another acronym.
Yes, it stands for. Define the problem and goals. Measure the current process performance with data. Analyze the data to find root causes. Improve by implementing solutions. And control, sustain the gains. Make sure things don't slip back. Very data-driven, great for tackling big systemic issues.
Wow, quite a range. Anything else notable?
The review even mentions specialized models, like a 5C cyclic model consultation, collection, consideration, collaboration, celebration developed for volunteer dental services in Aboriginal communities. Shows how adaptable CQI can be. And sometimes it's as straightforward as meeting-based approaches. Regular meetings with clear agendas, roles, tasks, and evaluation. Simple, but can be effective for driving progress.
That is a truly diverse landscape of models, clearly not a one-size-fits-all approach. But okay, let's drill down further. What about the specific tools? We've talked frameworks, but what are the actual instruments teams use to analyze, visualize, track progress? Because here's where it gets really interesting, the tangible things that help make sense of it all.
Absolutely. The models are the roadmap, but the tools are the vehicle and the navigation instruments. The review actually identified 19 distinct tools used in CQI. We don't need to list them all, but let's touch on some key ones.
19. Okay, give us the highlights.
All right. Think about tools for visualizing and diagnosing problems first. Simple things like checklists. Incredibly powerful, used for immunizations, maternal health checks, making sure critical steps aren't missed, like a pilot's pre-flight check.
Prevents simple errors.
Exactly. Then you have flowcharts. These help you actually draw out a process patient flow through a clinic, steps in surgery, how billing works, makes it much easier to visually spot bottlenecks or weird loops.
See where things get stuck.
Right. For digging into causes, cause and effect diagrams, often called fishbone or Ishikawa diagrams, are huge.
Fishbone, yeah. Looks like a fish skeleton.
That's the one. You put the problem at the head of the fish and then brainstorm potential causes along the bones, usually categorized like people, process, equipment, environment. Great for exploring all possible root causes for issues like hospital overcrowding or infection.
Organizes the brainstorming.
It does. And for even deeper root causes, there's why analysis. You just keep asking why, like a persistent toddler. Why is the wait time long? Because registration is slow. Why is registration slow? Because the computer system is clunky. Why? Until you hit the fundamental issue.
Gets past the symptoms.
Precisely. And when you have lots of ideas, affinity diagrams help group similar ones together, and multi-voting helps the team prioritize which solutions to tackle first. Useful when you've brainstormed, say, 20 ways to boost vaccination rate.
Okay, those help understand the problem. What about tracking progress? The measurement side.
Crucial part. For measurement and monitoring, time series charts and run charts are essential. They simply plot data points over time. Are infection rates going down after you implemented a new protocol? Is patient satisfaction going up? These charts show you the trend visually.
Like a stock chart for your process.
Exactly. Widely used in HIV programs, childcare, anywhere you need to see change over time. Then there are Pareto diagrams. These are based on the 80-20 rule, the idea that roughly 80% of problems come from 20% of causes.
So it helps you focus your effort.
Yes. Identify the vital few causes that are responsible for most of the issue, rather than getting bogged down in the trivial many. Maybe 80% of medication errors involve just 20% of the drugs. That's where you focus first.
Smart prioritization.
Definitely. And for more statistical rigor, you have control charts and p-charts. These are more sophisticated run charts. They help you distinguish between normal, expected variation in a process, Deming called common cause variation, and unusual spikes or dips that signal a specific assignable problem, special cause variation.
So telling the difference between background noise and a real signal.
That's a perfect analogy. Knowing if a dip in performance is just random fluctuation or something actually broke. These are used a lot for things like patient satisfaction scores, monitoring care consistency in radiotherapy, or maternal care outcomes.
Okay. Any others?
The review also mentions standard data visualization tools, tables, pie charts, histograms, box plots, star plots, variability graphs, all used to make complex data easier to understand, especially in areas like managing chronic diseases like diabetes. The sheer number of tools really underscores how data-driven CQI is. It's about using data to see the problem, track the change, and prove the improvement, bringing data to life.
Right, it's clear CQI isn't just a vague idea. It has these solid models, this extensive toolkit. But let's be realistic. Implementing this stuff in the real world, especially in a busy, complex hospital or clinic, it can't always be smooth sailing.
Oh, absolutely not. Real-world implementation is always messy.
So what gets in the way, and maybe more importantly, what helps things succeed? Because the review talks about barriers, but also facilitators, right?
Exactly.
Right.
And it helpfully groups these into 4 key dimensions: the cultural, the technical, the structural, and the strategic. Understanding these really helps anticipate roadblocks and figure out how to navigate them.
Okay, 4 dimensions. Let's start with cultural. That sounds like it's about people, mindsets. Probably the hardest.
Often, yes, because it involves changing behaviors and beliefs, common barriers here. Simple resistance to change. People are used to doing things a certain way. Maybe they don't want to learn a new online system or follow a new protocol.
Inertia.
Big time. Also, just a general lack of a quality-focused culture. Maybe quality improvement isn't seen as everyone's job, just something extra piled on top. But the real killer, often, is staff apprehension and fear of blame or punishment.
The no blaming thing we talked about. If
Yep.
that's not real.
Then staff won't report errors, they won't identify problems, they'll keep quiet to protect themselves, and the whole CQI engine grinds to a halt. The review points out that very hierarchical cultures, or ones focused purely on bureaucratic rules, can really stifle this. Specific examples: doctors refusing to join a CQI team, pharmacy staff not being involved in discussions, even something as simple as never celebrating successes that kills morale.
So how do you facilitate a better culture?
It takes deliberate effort. Actively developing a culture of CQI, fostering that shared mindset, commitment, psychological safety. This absolutely requires commitment from management, visibly supporting reporting, framing errors as learning opportunities, leading by example.
Walking the talk.
Absolutely. It means genuinely involving everyone: doctors, nurses, patients, families, support staff, leaders, promoting real teamwork and collaboration. And importantly, rewarding and celebrating successes, big or small, making people feel their efforts are valued, building that shared purpose.
That cultural piece is huge. Makes sense. Okay, what about the technical dimension? This sounds more like systems, data, skills.
Exactly. Barriers here often relate to resources and capabilities, things like inadequate support or capitalization, maybe not enough funding for a CQI facilitator role, or not enough time allocated for data entry. Big problems arise from immature or poor information systems.
Bad IT.
Yeah. Electronic health records that don't talk to each other, systems that are hard to get good data out of. You can't improve what you can't measure accurately. Another major barrier is simply a lack of training and skills. Staff might not know how to use improvement tools, interpret data, or even recognize opportunities for improvement.
They don't know what they don't know.
Right. The review mentions things like difficulty finding the right codes for conditions in the system, or missing key quality metrics altogether. Cripples data-driven work.
So technical facilitators are about fixing that. Better systems, better skills.
Pretty much investing in knowledge creation activities, ongoing training, seminars, workshops to build those skills. Ensuring data quality and availability is paramount. Maybe finding innovative reporting systems, like a hybrid manual online approach if the tech isn't perfect. And strategically focusing on a limited number of essential quality indicators. Don't try to measure everything. Measure what matters most and what you can realistically track well. Get the right data to the right people.
Okay, culture, technical. What's the structural dimension? Is this about how the organization is set up?
Yes, exactly. The actual organizational structure, communication flows, reporting lines. Barriers here include things like weak communication channels. Maybe doctors in different departments don't talk to each other effectively, or there's no good way to share learnings from one unit to another. Silos form.
Information gets trapped.
Right. Also, staff shortages and high turnover are huge structural problems. It's hard to sustain improvement efforts if the team keeps changing, or if everyone's just stretched too thin. Institutional knowledge walks out the door.
Makes continuity really difficult.
Immensely. Facilitators here focus on building better infrastructure, establishing effective communication forums, regular cross-department meetings, newsletters, shared dashboards, creating robust information and learning systems so knowledge gets captured and shared. Adopting systematic problem-solving approaches becomes part of the organizational structure. For you, the listener, this really matters. It's the difference between fragmented care, where your specialists don't seem coordinated, and smooth, integrated care, where everyone's on the same page because the structure supports it. Good ideas need the right environment.
That's a great point. Structure can enable or kill good ideas.
Okay.
Okay, last one. The strategic dimension. This sounds like top-level stuff, leadership, planning, resources.
You got it. This is about the big picture alignment. Barriers here include poor planning and goal selection. Maybe the CQI goals chosen aren't really linked to the organization's main strategic priorities, or CQI isn't integrated into overall planning, it's just seen as a side project.
It needs to be central.
Absolutely. Unaligned leadership is another killer. If the top bosses talk about quality, but their actions and resource decisions don't back it up, it won't fly. And very commonly, just plain resource inadequacy. Not enough money, not enough staff time, people overloaded with their day jobs. CQI gets squeezed out. Fragmentation of quality policies across different areas is another strategic barrier, no unified approach.
So what facilitates success at this level?
Strong, strengthened leadership is number one. Leaders have to champion CQI, visibly commit and allocate the necessary resources. Providing real support mechanisms is key things like mentoring for CQI teams, regular monitoring and feedback, supportive supervision, coaching.
Helping the team succeed.
Yes. Fostering participation, empowerment, and accountability for staff at all levels, so it's not just top-down. Involving all stakeholders, including maybe patients or even insurance payers, in decision-making helps build buy-in and collaboration. And sometimes practical things like incentivization, maybe compensating staff for CQI meetings held outside work hours, can show the organization truly values the effort. It really needs that holistic commitment, starting at the top.
Okay, it's clear that making CQI work involves navigating all four of those dimensions, culture, technical, structural, strategic. It's a complex dance. But let's get to the payoff. When organizations manage this, when the models and tools are used effectively, when these barriers are overcome, what actually changes? What's the real-world difference for you, the person getting care? This is the so what.
Yeah.
Right. The results.
Exactly, because ultimately this whole effort is about making care better, and the Endalamaw review gives us a really detailed picture of the positive impacts, helpfully structured using Donna Bedian's framework, structure, process, and outcome. But importantly, it also points out where CQI didn't always hit the mark, so we need to be balanced.
Okay, let's start with structure. How does CQI improve the foundations of the health system?
Well, it demonstrably improves leadership and planning. Organizations get better at monitoring, evaluation, strategic thinking around quality. It also impacts financing and costs. While there's an initial investment, maybe $2,000 to $10,500 per facility per year to get started, CQI has shown potential to maintain or even reduce operating costs over time. One estimate found average savings around $5,400 after implementation.
So an investment that can pay off.
Potentially, yes, by reducing waste and inefficiency. For the workforce, CQI helps with staff development, improves medical education, leads to better HR management. Staff tend to be more motivated, more aware of health issues themselves because they feel more involved and empowered.
That's interesting. A side benefit for staff, too.
Definitely. Though a small caveat mentioned was a concern about ensuring CQI's impartiality when integrated into medical education needs careful design. And finally, for technology and supplies, CQI leads to better registration and documentation, cleaner facilities, improved logistics, better availability of supplies and equipment, basic but fundamental improvements.
So it strengthens the whole underlying system. But what about the part the patient experiences most directly? The actual delivery of care, the process, and output.
Right, this is where you often feel the difference. Overall service delivery sees significant improvements. One study cited showed an 18% increase in overall quality of service performance.
18%, that's substantial.
It is. This translates into things like better patient counseling, staff adhering more closely to best practice procedures, better infection prevention, smoother workflows in clinics and hospitals. Things just run better, safer.
Less chaos, more order.
Kind of, yeah. Coordination and collaboration also get a big boost through data analysis, technical support, training, supervision, better links between teams. A journey through the system. Fewer communication breakdowns between your different doctors or departments.
That'd be nice.
Wouldn't it? Patient satisfaction generally goes up too. leading to improved quality of life because care is managed better, fewer nursing errors or delays. However, there's a nuance here.
Always a nuance.
Always. One study found CQI wasn't linked to changes in satisfaction specifically among adolescents and young adults. So, while generally positive, satisfaction is complex and maybe needs tailored approaches for different groups.
Okay. What about safety? This seems like a huge area for CQI.
Monumental. And the review gives concrete examples. Medication error reports dropping from 16 down to 6 in one initiative. Reduced use of inappropriate antibiotics. Fewer general errors in inpatient care. A significant drop in episiotomy rates during childbirth, from 44.5% down to 33.3%. Fewer cases of unplanned breathing tube removal. Better use of CT scans. More accurate diagnosis and treatment choices. These are direct impacts on patient safety, reducing harm.
Those are tangible life and death improvements.
Absolutely. Continuity of care also improves significantly, seeing the same provider more consistently. One study showed a 64% increase in provider continuity levels. Postnatal follow-up care for new mothers jumped from just 13% in 2012 to 74% in 2018 thanks to CQI. Better, more consistent care over time.
That's huge for mothers and babies.
Massive. Efficiency gains are also clear. Things like improved punctuality in cardiac catheterization labs. Emergency department discharge waiting time slashed from 76 minutes down to 22 minutes in one case. Average length of hospital stay after certain procedures reduced from 2.8 days to 2.0 days. Less waiting for you, faster recovery, better use of beds.
Makes the whole system work better.
It does. And accessibility often increases too. Better service coverage, higher utilization rates. Examples include improved immunization coverage, fewer patients missing scheduled surgeries, dropping from 3.9% to 0.9% no-shows, chlamydia screening rates jumping from 29% to 60%, increased HIV care coverage, much higher uptake of postpartum long-acting contraceptives, 6.9% to 25.4%, better use of antibiotics after C-sections, 36% to 89%, and a 31% increase in beneficial kangaroo care for newborns.
Wow, quite a list. Any caveats on accessibility?
Yes, one study didn't find a significant link between CQI and uptake of contraceptive services specifically, again highlighting context matters. Finally, acceptability among providers themselves is generally high. Most faculty, residents, staff find CQI useful figures like 88% of faculty, 64% of residents, 82% of staff in one study saying it helped. They see the value.
Okay, those process and structural improvements are impressive, really powerful. But the ultimate bottom line for many people is health itself. Does CQI actually lead to better health outcomes? Less illness, longer lives?
That's the critical question. And yes, the review shows CQI demonstrably impacts ultimate health outcomes, morbidity and mortality. We see better management outcomes for patients with diabetes, oral mucositis caused by cancer treatment, and anemia, reduced infection rates after C-sections. A significant drop in peritonitis for patients on peritoneal dialysis. The incidence went from once every 40 months per patient to once every 71 months. That's nearly double the time between infections.
Huge difference in quality of life there.
Immense. Preventing pressure ulcers, those awful bed sores, a 63% reduction within 2 years in one initiative. And overall, CQI initiatives have been linked to significantly reduced in-hospital deaths and increased patient survival rates. It's not just about efficiency, it's about saving lives and improving health fundamentally.
That's incredibly powerful. But you mentioned earlier, it's not always a silver bullet. Were there cases where CQI was not effective?
Yes, and it's important to understand why. For instance, one study looked at syphilis testing performance. CQI audit cycles didn't significantly improve it. Why? Possibly because the clinics involved just didn't prioritize syphilis testing among all the other things they needed to improve. It wasn't their focus.
So, lack of strategic focus undermined it.
Could be. Another example from South Africa. CQI-based mentoring didn't significantly boost the uptake of certain facility-based interventions. The reason suggested was that baseline attendance was already quite high, leaving little room for improvement.
So, diminishing returns, perhaps.
Possibly. These examples really highlight that CQI is highly context-dependent. It needs consistent prioritization by the organization, genuine effort from the teams, and frankly, there needs to be a real opportunity, real room for improvement to show a measurable impact. It's a powerful tool, but you have to apply it thoughtfully and strategically, understanding the specific context and limitations.
That gives us a really comprehensive picture. CQI can have these profound impacts, from structure to process to life-saving outcomes, but its success isn't automatic. It depends on context and commitment. So, stepping back, what's the bigger picture here? What does all this mean for the future of healthcare and for you, the person receiving care? Where do we go from here?
Well, beyond the specific improvements we've discussed, CQI has really significant implications for broader health policy goals. It's seen as playing a vital role in advancing primary healthcare, PHC, globally.
Primary care, the front line of healthcare.
Exactly. And also achieving the goals of universal health coverage, UHC, ensuring everyone can get the quality health services they need without financial hardship. The kinds of indicators CQI improves accessibility, efficiency, quality, safety. These align directly with what makes PHC effective.
So CQI helps build stronger primary care systems.
Yes. By implementing CQI methods consistently, countries can make their PHC services more accessible, more affordable, higher quality. This leads to better population health outcomes and helps them use their resources more effectively. It's really foundational for building equitable, high-performing health systems worldwide.
That connects it to some really big global health goals. Now, you mentioned knowledge translation earlier. How does CQI relate to that? Are they the same thing?
Good question. They're related but distinct. Think of it this way. CQI primarily focuses on improving existing processes within systems, making workflows better, reducing errors, boosting efficiency in how care is currently delivered. Knowledge translation, KT on the other hand, is about bridging the gap between research evidence and actual practice.
Getting new science into use faster.
Exactly. Taking findings from clinical trials or health services research and translating them into actionable knowledge and tools for practitioners at the bedside. So CQI improves the how, while KT focuses on incorporating the what, the latest evidence.
But they work together.
They definitely can, and ideally should. KT can feed new evidence into CQI cycles, ensuring improvements are based on the latest science. And both share that core principle of continuous learning and striving for betterment. They're complementary forces for improving healthcare.
Okay, that clarifies the KT distinction. Now, every review has its limits. What were the limitations of this specific scoping review by Endalamaw et al.?
They acknowledged a couple of key ones. Firstly, they only included articles published in English, so potentially valuable research on CQI happening and being published in other languages would have been missed.
The language bias.
Right. Secondly, because it was a scoping review, its main goal was to map out the existing evidence broadly, what models are used, what outcomes are measured, where is it being done. It wasn't designed to critically appraise or score the methodological quality of each individual study included.
So it gives breadth, but maybe not depth on study quality.
Exactly. It synthesizes what's out there, but doesn't necessarily say this study was stronger than that one. That would be more the focus of a systematic review with quality assessment.
Understood. And based on their scoping work, did the authors identify areas where we still need more research, remaining research gaps?
Yes, they highlighted several important areas where more rigorous research is needed to fully understand CQI's impact. We need more studies looking specifically at how CQI affects things like catastrophic health expenditure, does better quality care prevent people from facing ruinous out-of-pocket costs?
That's a huge issue for many people.
Absolutely. Also, impact on effective service coverage, true patient-centeredness, going beyond dissatisfaction surveys, the comprehensiveness of care provided, equity across different population groups, health security, and the overall responsiveness of health systems to patient needs.
So broadening the scope of outcomes measured.
Yes, and measuring them rigorously. The authors strongly emphasize the need for more scale-up implementation research. Because CQI is so context-dependent, as we've discussed, we need research that explores how to effectively adapt and implement CQI initiatives across diverse settings, different countries, different resource levels, urban versus rural. Understanding how to scale it up effectively is really the next frontier. Hashtag outro.
That really brings us full circle. Continuous quality improvement.
Yeah.
It's clearly not a static program, but this ongoing living intervention. It's driven by dedicated teams working in these adaptive cycles using a whole toolkit of models like PDSA, Kaizen, Lean Six Sigma.
Dynamic process.
Absolutely. And we've seen how its success hinges on navigating that complex interplay of culture, technology, structure, and strategy within an organization. It's this constant evolution shaping how healthcare is delivered every day.
Always striving for better.
And the ultimate goal, as we've explored, is truly profound. It's about strengthening the very foundations of our health systems, making the services you receive safer, more effective, more efficient, and ultimately contributing to less illness, better health, and longer lives for you, the patient, and for everyone. It's this quiet, relentless revolution happening behind the scenes.
Which leads to a final thought, perhaps. If continuous quality improvement is so inherently context-dependent, thriving on understanding the specific environment, it raises an important question.
Oh.
How might understanding your specific healthcare context, whether you experience it as a patient, work within it as a provider, or influence it as a policymaker, how might that understanding empower you to advocate for or even contribute to these vital improvements? What small, continuous deep dives can you make in your own understanding, in your own sphere, to push for broad quality in the systems that serve us all?
That's a powerful question to leave us with. Food for thought indeed. Thank you for joining us on this deep dive into continuous quality improvement in healthcare. Keep exploring, keep learning, and keep asking how things can be made just that little bit better. We'll see you next time.